I now take the pleasure of inviting my great friend Dr. G. N. Mahapatra, who is a very dedicated nuclear cardiac imager. And he is known for his leadership skills in World Affairs, and he founded the World Federation of Cardiac Imaging and Clinical Cardiology. He is also in the editorial board of JAC Cardiac Imaging. Over to Dr. Mahapatra. You can carry on, please.
In our next 12 minutes, I will be speaking on role of PET in evaluation of coronary and carotid plaques. We'll start with coronary, and later on I'll show you the carotid plaques also. Okay, all our present understanding of major cardiovascular events is centered around the atherosclerotic plaque and the process that leads to acute plaque rupture producing myocardial infarction. Atherosclerosis is characterized by lipid deposition within the arterial intima, represents a nidus for inflammation. This lipid becomes oxidized, triggers an inflammatory response constituting a macrophage. These macrophages engulf lipid particles to form foam cells. So these foam cells induces pro-inflammatory cellular phenotype, promote ongoing inflammation, cell death, and potentially leading to acute plaque rupture and atherosclerosis leading to acute event. So nuclear cardiology procedures has distinct advantages over other diagnostic imaging modalities, such as having a low radiation risk because of low amount of radioactive traces are used. It is being relatively painless and non-invasive and provides both structural and functional information superior to other non-invasive invasive tests like MDCT, MRI, OCT, and IVUS with a 93% sensitivity and all. So new innovations such as molecular imaging now offers an array of tools to develop advanced diagnostic approaches. Understanding the pathophysiology of atheroma makes it possible to identify vulnerable plaque based on its metabolic signature or the presence of excessive apoptosis. Because of its large metabolic and apoptotic signals, even the small lesions can be visible. Recent advances in hybrid imaging, particularly PET-CT or PET-MR, that increases the high spatial resolution and anatomical detail with molecular assessment of disease activity. This provides the ability to identify vulnerable plaque characteristics, which I'll be speaking one by one, and differentiate active, hot, unstable plaque from a quiescent, stable disease activity to improve the patient stratification. Inflammation within the plaque has been extensively documented, and imaging with F18 FDG has been in different vascular strategies with limited success with the physiological uptake of FDG. So, who are the patients to be benefited in this plaque imaging? Acute coronary syndrome. Acute coronary syndrome in MI group, continuous chest pain lasted for more than 30 minutes, new left bundle branch block, elevated cardiac troponin T, chronic stable angina with positive treadmill test, and abnormal myocardial perfusion scan. So what are the exclusion criteria? Patient with pregnancy, of course, history of allergy to iodinated contrast material, history of renal dysfunction in post-MI with serum creatinine more than 1.5 mgd per deciliter, inability to hold breath, patients with arrhythmia, particularly of post-MI and hemodynamically unstable patients. So what are the PET radiotracers available in plaque imaging? You know very well, for last 2 decades, we have been using F18 FDG for oncology imaging or neurology imaging that can be used. I'll tell you in what condition and where. Then the second one is really the molecule of the millennium, that is called F18 sodium chloride. Then third one, again, it is a very good for neuroreceptor imaging, that is called neuroendocrine imaging, gallium-68 dotactate or copper-64 dotactate or C11 PK triple 195, then fluoromisinazole, fluorocholine, gallium-68 nota RGD, gallium-68 pentaxifor. And what are the characteristics of unstable and ruptured culprit plaques? Extensive inflammation, a large necrotic core, as Dr. Suman has just mentioned, a thin fibrous cap. In inflamed lesions, this cap becomes thinned and weakened by the action of matrix metalloproteinase, predisposing to rupture. Then positive remodeling with a large plaque volume. Then microcalcification, then neovascularization, in atherosclerosis a major role in plaque growth. So this is the vulnerable plaque which Dr. Suman has already shown. So this is a small, big necrotic core. This one is, I'll just a pointer, I'll get the previous pointer. So this is the necrotic, big necrotic core. These are the neoangiogenesis things, and this is the spotty calcification, and these are the macrophages. This is a small lumen. Then this is a stable plaque and an unstable plaque. Unstable plaque in the right hand side, you can see the left hand side is the stable plaque. So you can differentiate how unstable is it. So this is a molecular target, how different radioisotopes they work. In macrophage level, the FDG worked, F18 FDG, and also the gallium-60 dotated because that expresses the somatostatin receptor on the macrophages. Then we have got microcalcification, the right-hand side corner, sodium chloride. There are microcalcifications. Then NOTA and RGD for remodeling imaging. Then the hypoxia imaging, FISC imaging. So starting with 18-fluorodeoxyglucose, PET F18 FDG, as I have told you, it has been used in oncology for many years and was first utilized to image atherosclerosis in the cardiac. It accumulates intracellularly in tissues with high metabolic activity and does not have any affiliation with the microcalcification, F18 FDG. FDG affiliation due to macrophage infiltration as a part of inflammation and therefore been used as a non-specific marker of vascular inflammation in aorta, carotid, and femoral. So, but coronary artery uptake is often obscured when you use F18 FDG because of the myocardial uptake. So, therefore, quantifying the vulnerable plaque in smaller coronary arteries remains a challenge when we are using previously F18 FDG because the spatial resolution limited to 6 mm. But significant cardiac and respiratory motion that further degrade the PET signal, complicating assessing of mid to distal coronary artery. Yes, so now this is the molecule F18 sodium chloride. It has been used as a bone tracer and for the detection of bony metastasis, but has now found a potential application in hybrid cardiac imaging. The ligand F18 sodium chloride is a hydroxyapatite key component of early vascular microcalcification as it binds to micro rather than macro calcification due to the higher exposed surface area of hydroxyapatite. So microcalcification is thought to be an early healing response to cell necrosis and inflammation that precedes the development of larger macroscopic deposits of calcium which can be converted to a stable plaque. So we can detect with the microcalcification in fibrous cap may also increase local stress and destabilize the plaque leading to rupture. So sodium chloride, F18 sodium chloride appears to have low uptake in the adjacent myocardium and a very high affinity of the tracer to the microcalcification in the plaque, in the unstable plaque. So what is the mechanism of action? An event-prone coronary plaque has a thin cap, as you know all, with a necrotic core, but the initial phase of inflammation sets off within the plaque due to multiple underlying risk factors leading to microcalcific foci, which tend to have a higher risk of rupture. So fluoride uptake is an indicator of calcification within the plaque. In that active phase, calcification leading to penetration of the tracer F18 sodium chloride to the ruptured plaque and gets tagged. So here you can see there is a totally a subtotal or a complete total lesion of the LAD artery in the left hand side of the angiogram, and here you can see the intense uptake of the sodium chloride and the proximal region of the LAD, which you can see over here. So this is the same thing where the graphical representation was to show that the culprit plaque has got a very good tissue background ratio of accumulating sodium chloride as compared to non-culprit. So then the next comes the gallium-68 dotated. These are the target receptor that expressed onto the macrophage. Then it has been demonstrated exclusively expression of somatic receptor in macrophages within the atherosclerotic plaque, showing improved discrimination of culprit and high-risk plaque in both coronary and cardiac. See one slide. One patient underwent a sodium fluoride PET CT, demonstrated 3 discrete regions of focal uptake in the proximal, mid, and distal RCA. The highest uptake is similarly. So if you can see here, there are three multiple lesions of the gallium-68 dotted and showing multiple areas of intense uptake. But as compared to here in the lower images, there is this is called a stable plaque. So hardly there is any uptake in the proximal LAD in the lower side. But upper side, there are 3 lesions which shows that gallium, that the effect in sodium chloride has got a beautiful uptake. So now from coronary to move to the vessels, F18 FDG PET CT in the evaluation of vascularity. So I will show you a very good case of Takaisu in the stage of vasculitis, not at the level of not at the level of stenosis. So it may be Takaisu or it may be Janssen arthritis, but I'll show you a very beautiful case. Vasculitis is defined as an inflammation and necrosis with the leukocytic infiltration of the blood vessel. Takaisu arthritis is a chronic inflammatory arthritis that primarily involves the aorta and its main branches, which Dr. Megha showed that lesion is stenosed and this thing. But I will show you at the level of arthritis how F18 FDG has picked up those things much early from the stenosis. So F18 FDG PET metabolic imaging is nowadays used in the investigation of patients with large vessel vasculitis. So it reveals the extent of the disease and is highly effective in detecting large vessel vasculitis anywhere in the body and has a high sensitivity specificity. It can be monitored, particularly of large vessel inflammatory and disease activity after you see that and find out and then put the patient on immunosuppressive therapy. That also I'll show you, such as prednisolone and cyclophosphamide 110 mg per day. Following 2 months, we repeated again the PET CT. Now have a look. Here.
Dr. Mahapatra, kindly conclude your
slides.
Yeah,
it will about 2-3 minutes. So it is showing the whole abdominal aorta is showing increased uptake among and also the both subclavian artery is showing the increased uptake of F18 FDG. After putting the patient on prednisolone and cyclophosphamide after 2 months, we repeated. Then he saw that they're totally gone and totally cured, and there is no vasculitis either there in the aorta, abdominal aorta, or in the subclavian arteries. So this is another case of vasculitis which shows multiple intense uptake is shown in all the abdominal aorta. That is called a vasculitis. Here, the interesting case, the PET CT shows multiple lesions of intense uptake in the aorta, and the CT calcium shows nothing, and fused image shows there are multiple increased FDG uptake in the arteries, so that this is more sensitive than the calcium score. So concluding, nuclear cardiology procedures are no doubt the state-of-the-art procedures in the present-day clinical practice in diagnosis, prognosis, and guidance of therapy in CAD and non-CAD patients. The field of cardiovascular atherosclerosis imaging is burgeoning with increasing availability and uptake of CT PET. Hybrid imaging platforms combine these modalities with PET, which together provide detailed information about coronary anatomy, flow, plaque morphology, and disease activity, expanding our pathophysiological understanding of atherosclerosis and improving risk stratification. Further, what I showed you effect in sodium chloride uptake value in magnitude can be used as a criterion to differentiate between culprit and non-culprit plaques in MI patients' usefulness in cases of multivessel disease. Thank you very much for your attention. I would like to invite to come as a attendee or as a faculty for our 3rd World Congress in Cardiac Imaging and Clinical Cardiology at Tajlands Hotel in Bandstand, Mumbai, Bandra West from 28th to 30th October 2022. Hopefully, the corona should settle down. Thank you very much for giving me an opportunity to speak. Thank you.
Thank you, Dr. Mahapatra. Then the floor is open for discussions. We will take a couple of questions for a few minutes.